fractures of the distal part of radius. I will start with Colles fracture. Okay, Colles fracture is a transverse fracture of the radius just above the wrist. Okay, with dorsal displacement of the distal fragments. So we have a transverse fracture of the distal part of the radius with the fragments that resulted from this fracture distally or dorsally displaced. Okay, this is Colles fracture. Colles fracture is caused usually by falling down on outstretched hand with extreme dorsiflexion of the hand, extreme dorsiflexion, and this dorsiflexion is a result of trying to ease a fall. You have the patient just try to make the fall easier, so he dorsiflex his hand and Colles fracture result. Okay, by the way, Colles is the most common of all fractures in older people, and this is due to osteoporosis. So Colles is the most common among fractures, okay, in older people. Okay, the patient who comes to you is usually an older woman who gives a history of falling down on her outstretched dorsiflexed hand. Okay, and a lot of these females or males patient comes to you with a special feature. Okay, this special appearance or feature called dinner fork appearance. What is dinner fork appearance? It is a prominence on the back of the wrist, with depression on the front. Let me just put lines. Prominent in the dorsal of the wrist, and okay, depression on the front. Here again, prominence and depression. This is dinner fork appearance. Okay, on X-ray we are able to see transverse fracture. This is transverse fracture. Again, just point this transverse fracture. Sometimes the patient comes with a styloid process displacement. Of course, the transverse fracture of the distal part of the radius. Okay, so what is the treatment of Colles fracture? The treatments actually of Colles fracture depends on the presence of displacement or not. Do we have displacement or not? If no, we don't have displacement, then we just apply a dorsal splint. We put what we call a dorsal splint. Dorsal because it's in the dorsal part of the arm and hand. Then, after the swelling resolves, we apply a full cast. So the target behind just putting dorsal splint is waiting for a swelling to resolve. After resolving of the swelling, we put a full cast. Okay, so after this complete cast, we wait 4 to 14 days. We wait 10 to 14 days. After this, we make some X-rays of the hand to make sure that there is no slipping. So if we have no slipping, then we keep the cast for 4 weeks. Okay, if we have slipping, we have to do open reduction and internal fixation. Okay, so again, dorsal split. After dorsal split, we wait just the swelling to resolve. After that, we put full cast. Then we wait 10 to 14 days. After this, we make X-ray to show any slipping. If there is no slipping, we have to keep cast for 4 weeks. If there is slipping, we have to do open reduction and internal fixation. In the case of displaced coils, what we have to do is close reduction under anesthesia, of course, okay? So this reduction is done by many steps. First of all, we have to grasp, before starting the maneuver, of course, don't forget to do neurovascular examination to make sure that there is no medial nerve or other nerves entrapment, okay? Okay. By studying the maneuver, we have to grasp the hand and apply a traction, sometimes with extension of the hand to disimpact the fragments. So we have to grasp the hand, apply a traction with some extension to disimpact the fragments. After that, we have to push and place on the dorsal part of the hand to reduce the fragments to place, okay? While this, we have to manipulate the wrist into pronation, flexion, and ulnar deviation. Pronation, flexion, and ulnar deviation. So this is how we do close reduction, by traction, reduction into place of the fragments, with pronation, ulnar deviation, and somehow flexion. Okay, after reduction, we have to repeat neurovascular examination and to repeat X-ray to make sure that displacement is good enough. If yes, displacement is good enough, we have to put dorsal slab. Oh, sorry, not forecast, dorsal slab. Just make it correct. Okay, but dorsal slab. Okay, of course, this slab will extend from below the elbow, just below the elbow, from the dorsal part to the metacarpal joint. Okay, with 2/3 of the way around circumferences of the wrist closed by the slab. Okay, we can, after this, just close the arm with a crepe bandage. Okay, this is not very important. Okay, the outcome in old people is good, but in young people is poor. It is poor in young people. Just now move to complications of Collar's fracture. Complications are divided into early and late complications. The early complications, the most important of them is neurovascular complications, okay, injuring some blood vessels or nerve. This is an early complication. Medial nerve, of course, is the most common to be injured, causing numbness, paresthesia, pain in the lateral 3 fingers of the hand, just like what happens in carpal tunnel syndrome as a result of medial nerve compression. Okay, in some cases, irritation, okay, thinner atrophy is possible too in medial nerve compression, muscle relaxing and wasting, etc. Okay, in some cases, irritation of medial nerve causes abnormal excitation of nervous tissue, okay, leading to abnormal sympathetic stimulation or excitation, leading to some symptoms. This is what we call reflex sympathetic dystrophy. Reflex sympathetic dystrophy, an injury to the medial nerve. This injury causes pain and some irritation. This irritation will cause some impulses, which goes to the central nervous system. After that, to the sympathetic stimulation, causing sympathetic stimulation and some symptoms as a result. Okay, redness, as we can see, this is reflex sympathetic dystrophy, redness, hotness, sometimes coldness, and paresthesia, sweating, etc. Okay, these are two early complications: medial nerve or medial nerve injury, neurovascular injuries, and post-traumatic reflex sympathetic dystrophy. What about late complications? As usual in fractures, late complications include, in the first place, mal or non-union. Okay, we here can see mal-union, okay, or non-union. Another late complication is extensor pollicis longus rupture. Okay, rupture of the extensor pollicis longus muscle and tendon, causing a problem in extending the thumb. The thumb is not extended anymore. Okay, early complication, late complications. Early complications like neurovascular complications, medial nerve injury, sympathetic reflex sympathetic dystrophy as a result of the injury. The central nervous system will put some impulses to the sympathetic autonomic nervous system, causing swelling, hotness, redness, and other warmth and other symptoms. Okay, late complications again, mal or non-union, and extensor pollicis longus rupture leading to failure of extension of the thumb. Okay, thank you. See you in the next video.